In the papers, I've been reading quite a lot saying, where the doctors are having to make tough choices about who to send to ICU or not. That is every single day. Every week in South Africa, in my hospital, many young people are sent home to die. In their teens, 20s, 30s. Every day we make decisions based on our resources. And this is now something that high-income countries are having to face and are not used to it. And it is really hard and stressful and horrible. But that is what South African doctors and the workforce and the healthcare professionals are used to.
In Zimbabwe, the epidemic manifesting itself in the huge steep rise in the number of cases and hospital admissions lagged behind Europe, and we started to see a rise in hospital admissions and cases in the first, i.e. our first wave around June, July 2020. Essential fears were lack of staff, lack of infrastructure, lack of enough beds, guidelines for public health measures and infection prevention control that were relevant to our context. Specifically, one other additional concern that I had was if we did engage in lockdown, which actually we did for 6 weeks around March, April of 2020, the impact it would have on the economic, social, and political, cultural fabric of society, given that the vast majority of people are daily wage earners. And we really don't have the sort of social protection mechanisms available to support people who were not able to go to work, etc.
The other thing which was very characteristic, it became synonymous with COVID. And you ask anybody in this hospital to describe what COVID sounds like, and it was the sound of the hissing of high flow oxygen in the wards. These machines make a hiss, and that stays with you. It's almost like being on a boat and feeling a bit motion sick, or the ground's moving. When you leave those wards, you can still hear this.
There was no public transport available over the period that we were having a wave. And to get patients from their homes to the hospital was a very big challenge. We take ambulance systems, etc. for granted. We take public transport for granted. A lot of people had no access to any of that. We used to spend a disproportionate amount of time trying to work out arrangements to get people to hospital when they needed it, which meant that many patients arrived very late, far too late for us to be able to make any difference.
In oncology in particular, we are seeing that patients are not getting the care that they need, and this is going to be directly seen in the results when it comes to their disease. I'm not really being over dramatic. I think it's going to be catastrophic. We're going to see a lot more of patients with terminal or incurable disease down the line that could have been cured. We are even seeing it now, like patients who were supposed to come for a checkup, or patients who were supposed to come for a procedure 3, 4, 6 months ago, and they didn't do so because of fear of the pandemic, of fear of COVID. And now they are in a point that we cannot even treat the disease. Unfortunately, since we're not going to be able to diagnose them quickly enough, most of them are going to be diagnosed at a later stage, which has dramatically negative impact on their prognosis as well as the treatment that they can receive.
We always try and do the maximum for each of our patients, but because of resource allocation, you have to make tough decisions. And COVID was a lot about making tough decisions about who should get high flow nasal oxygen, who shouldn't. There's an enormous amount of stress and hurt. What we're seeing now is a lot of post-traumatic stress, I think, disorder though in our staff.
It's difficult to describe how to process is when you don't have a bed and you're rung up by a number of people, relatives, other doctors, other colleagues asking to admit patients, and you don't have the capacity to admit them. It's an extremely difficult thing to say, I'm sorry, I don't have a bed.